And I am really delighted to introduce the best clinical abstract, which will be presented by Dr. Michael Maschan from Moscow. Larissa Shelikova, who is the first author of this abstract, was unable to present today. The title of this abstract is TCRαβ CD19 depletion in hematopoietic stem cell transplantation from haploidentical donors in pediatric acute lymphoblastic leukemia patients in complete remission. I hope Dr. Maschan is there, and we are here whenever you want to start.
It's a real honor that our abstract was selected for this best clinical abstract, and I'm presenting this on behalf of my co-author Larissa Shelikova, who actually analyzed the data and took care of most of the patients presented here, and also, of course, on behalf of the team from Dmitry Rogachev Center in Moscow. As you know, I think over 15 years ago, we took Rupert's idea of creating a perfect designer graft with this immunomagnetic selection technology really seriously. We started with some early experience with CD19 depletion, and then in 2012 we switched to TCRαβ depletion as a key platform, actually, not only for haploidentical transplantation, since we thought that the kind of problem we come across in unrelated is more or less the same with severe GVHD, high rate of chronic GVHD. So we did a lot of alpha-beta depleted transplantations, both in unrelated and haploidentical. And it was a 10-year journey when we made some effort to improve the approach with some prospective trials concentrated on the immune reconstitution by means of adoptive transfer of memory T cells derived from the donor. So you could have seen that. But today, we never actually had a special prospective trial dedicated to acute lymphoblastic leukemia, although ALL, of course, is the #1 indication in pediatric malignant hematology and transplantation. So we wanted to present here a retrospective analysis, and the entry criteria are presented here. This is a retrospective study, although a proportion of patients, I think over 70% of the patients presented here were actually enrolled into other prospective trials over 10 years. With all patients who received alpha-beta depletion were prospectively put into a clinical database, and we selected ALL patients with classic standard indications. All ALL patients who were transplanted from haploidentical family donors received their first transplant in complete remission by morphology. And the median follow-up for the group is now around 4 years. So here are the cohort characteristics. So you can see the median age is around 9 years. That's immunophenotype is more or less standard. You can see the remission status with 34% of the patients transplanted CR1. And a flow-based MRD measurement was available for 90% of the patients, with 65 going into transplant negative MRD and 26% with positive MRD. This cohort includes 202 patients, all grafted with alpha-beta and CD19 depleted graft with the median alpha-beta of 27,000 per kilo and almost 10 million per kilo of stem cells. Here, mismatch was predicted for almost 30% of the patients by standard old-fashioned ligand model. Here, typing was not available, and the conditioning regimen was TBI in almost 70% of the patients, and myeloablative high-dose treosulfan was used in 33% as a basic agent. Approach to serotherapy was evolving. During early years, during the first 2 years, we had only access to horse ATG. Then for a while, we used thymoglobulin. And then for a prospective trial of memory DLI, we used a novel approach with completely omitting ATG and replacing it with one shot of tocilizumab and a shot of a dataset. And you can see this evolution in more detail. So the standard conditioning is, it was always an intensive conditioning with either TBI with the second agent, usually thiotepa, and later with etoposide, or triosulfan with either melphalan or later thiotepa, or later also etoposide. And as I said in the last part, we had this abatacept tocilizumab replacing ATG. So today I just wanted to share the mostly univariate analysis and a little bit of MVA, which we did last year. So early results, we had lost 4 patients to bacterial infection before engraftment, and there were 5 patients who did not engraft and were actually salvaged by second transplantation. So the engraftment rate for survivors, for those who could be evaluated at day 30, was 98%, with a median time to neutrophil and platelet engraftment of 13 and 14 days, respectively. The incidence of acute GVHD in the total cohort is 14%. It was maybe slightly worse in the abatacept toci group, but this was not statistically significant, as you can see. The incidence of chronic GVHD was 15% for the full cohort, with just over 3 of severe cases, and importantly, actually, in all cases, we were able to almost, besides one, we were able to stop immune suppression, and all the survivors were free from immune suppression of last follow-up. Regarding the ATG use and donor effects did not affect acute GVHD rate, but interestingly, in the absence of ATG, we had even lower rates of chronic GVHD, and there was no difference by donor sex. Transplant-related mortality at 4 years now is 9%. There were, as I said, 4 cases of septic events before engraftment, and there were a bunch of mostly viral problems, some of them due to pandemic, and many cases of patients who were lost to ongoing immune suppression and viral or mixed infections. So more or less typical for this type of transplant. The incidence of relapse was 31% at median follow-up of 4 years. And going into details, the role of conditioning regimen, which was discussed yesterday and also today, there was slightly high rate of relapse in the non-TBI conditioning, 26%, versus non-TBI 39% versus 26% for TBI, not reaching statistical significance in this case. And the transplant-related mortality was not different at all. The use of ATG, and we've reported on this before, actually, in the absence of ATG, we've seen a lower transplant-related mortality, and it was shown that emission of ATG was, in our series, actually associated with an improved early immune reconstitution, while for the acute lymphoblastic leukemia, the use of ATG did not really affect the relapse rate, at difference to the acute myeloid leukemia, which I'm not talking today, but this was published very recently in a paper by Svetlana Glushkova in Transplantation Cell Therapy, so you can refer to this for greater detail. The major factor affecting the incidence of relapse was minimal residual disease. That was, as I said, flow-based MRD, MRD negative patients had 24% incidence of relapse compared to 51% in those who went to transplant with an MRD positive disease. And the CR status, like patients grafted in first CR, had better outcomes compared to CR2 and CR3. And it was also close to a significant case. Regarding the long debated and discussed question of deficit of cure mismatch, as I said, we didn't have access to cure genotyping. So based on ligand prediction, we see absolutely no sign that cure mismatch for this cohort actually is important. And again, this was recently published in details. Going to survival, the overall survival for the whole cohort is 69%, event-free at 4 years, 59%, and GVHD and relapse-free survival of 56%. In the reactivation and mother versus father on donor sex did not have much effect on the event-free survival. As well as leukemia phenotype didn't play out, while CR number was close to be important. Minimal residual disease affected with a trend the event-free survival and also overall survival. The conditioning regimen, here we see a statistically significant difference with almost 20% difference in favor of TBI-based regimen for event-free survival. Interestingly, for overall survival, the curves are completely superimposable, and we believe this is due to two factors. First is that CD19 targeting by either Blincyto or CAR T cell became available at a certain time point in 2018. And the second is that we were really eager to perform a second transplant, TBI-based. So those who didn't receive TBI during the first transplant were able to receive TBI during a second transplant. And as I said, we do a chemotherapy, helical chemotherapy-based TBI, which is associated with a very modest non-relapse mortality compared to like regular TBI regimens. In the multivariate analysis, minimal residual disease was the most important factor affecting the relapse incidence, event-free, and overall survival. TBI played out as a still significant factor in VA and CR number also for relapse and survival. And here, this is presented in a table way just for you to see the hazard ratio and the significant level, which is high, especially for the relapse incidence. So to conclude for this cohort, we believe that TCRαβ depletion is a solid platform for haploidentical transplantation among children with high-risk acute lymphoblastic leukemia. In this analysis, MRD, CR status, and total body irradiation remain important factors affecting relapse incidence and survival. Omission of ATG or replacement of ATG with a targeted immune modulation and and tocilizumab appears to improve non-relapse mortality, and we believe this is associated with early immune recovery of T cells. And cure mismatch and donor stats don't appear to affect the outcome, so we wonder if we should still really use NK factor or cure mismatch as a selection factor for the donor, as well as in the reactivation and patient age. And this finish, we share the ideas of Rupert and thoughts of Alicia and many who were speaking today and yesterday that this is a platform, so we can add something, and we've done some some patients also in a pilot trial trying to combine a donor-derived haploidentical CAR T cells with the alpha-beta depleted platform. So we hope to be able to publish this in the near future. We've done 17 patients with this approach. And just to illustrate our first patient who received this type of approach, who actually relapsed after CD19 CAR and received transplant with the donor-derived 1922 CAR T is now 4 years in remission. And at least for 2 years, we were able to detect CAR T cells in his blood, and it was B-cell-plastic. So with this, I would wish to thank the team of Dmitry Rogachev Center, and thank you all for your attention, and organizers for this beautiful meeting. We still, although we had to switch due to dire circumstances to a different platform now, but we hope that their times will, and then we'll be able to be back in the family of alpha-beta depletion. Thank you.
Thank you very much, Michael. It's very nice to see this high number of patients line up. I think that the number that stick to me is these relapse incidents that remain, no matter how we turn the patients in terms of conditioning regimen, we still all have about 25% relapse. I think that Mike Pulsifer data showed that with the NGS MRD negative, we can do better, although I think we need to have a longer follow-up to really see what's going to happen with the late relapse. But again, as a group, I think what we have to invest on is in strategy to reduce post-transplant relapse. We have an excellent platform that's already giving really a very good results, and now we need to try to do the next step in reducing the leukemia recurrence. If there are, do you have any other thought beside the CAR on how to do that?
I couldn't tell whether.
Well, I think that
I couldn't tell whether your protocol is the routine administration of CARs afterwards, or are you using CARs afterwards to rescue people that relapsed?
Actually, to give you a little bit more detail on the use of CAR, we use this in a very selected group of patients, most of whom were actually not even MRD positive, but could not be induced into remission by any available drug. So those who failed previous transplants or previous CAR T therapy. So at least half of the patients who were treated with this approach were actually active disease, which we never did before for acute lymphoblastic leukemia. And having in this cohort around 50% survival now is something that makes us feel that this is a possibility, I would say. But I should admit that I would say that any immunotargeting by antibody, as Rupert suggested yesterday, by Blincyto, by inotuzumab, as published recently from MD, low dose, could be used with this platform, since the platform itself is associated with so little toxicity, and we're able to actually withdraw any immune suppression very early post-transplant, like at day 30, all the patients are off any immune suppression, or most of the patients, like 85% of the patients are off immune suppression. So I think this gives us the opportunity to add a number of drugs. This could be CAR-NK, CAR gamma deltas, or a mix of approaches.
But I guess the question is, giving back to Chris's idea that he wants to get rid of TBI, is to routinely give CARs afterwards for all patients that did not have, had detectable disease at the time of transplant.
Yes, I think that this could be a possibility, and this is something we would be happy to be part of, to omit TBI and to replace it with a CAR T before and after. So I think this is an interesting approach, and to do that, we have to keep some B cells in the graft. So for this cohort, we omitted the CD19 part of the processing, so to keep some B cells in the graft to stimulate the CAR T.
Hi, Dr. Maschan. This is David Shire at Stanford. Excellent talk. Thank you so much. I find it very interesting and provocative that the removal of ATG from the PrEP. Can you elaborate about the rationale leading to your institution making a decision? At least, like, we always think that the ATG has something to do with preventing graft rejection, but that didn't happen with your data. Yeah, please, can you? And then, do you have chimerism results showing early post-transplant? Is there any sort of change in pattern? Thank you.
Thank you so much for the question. Actually, this was the reason was multiple. First of all, we always thought that this overshoot of ATG might damage the precious like NK cells and gamma delta cells, which we infuse. But the real practical reason was that after like first years of using this approach, I think that thymoglobulin is a little bit more immune suppressive maybe compared to the graft alone. So we still had problems with the viral infections. And then we came to an idea of making this very, very early infusions of low doses of memory T cells. We wanted to infuse the CD45 array depleted memory T cells like on day 0. And to do that, of course, we had to do something with the ATG. And well, I agree that there were like kind of two approaches. First, moving ATG distal to the graft infusion. But since we didn't have really any problems with engraftment, very rare non-engraftment patients at that moment, we took this. We planned a randomized trial with the memory T cell infusion where we wanted to have a really very clean environment for these small doses of memory T cells. And in the trial, this was a large trial of 150 patients. The rate of rejection was, I don't know, 1% maybe, or 2% at maximum. So we didn't have problems with rejection without ATG. But the conditioning, even with triosulfan, there were two alkylators always, trio-thiotepa, most popular regimen. So I think the conditioning was intensive enough to ensure engraftment. Regarding the chimerism in malignant indications, we didn't see any real change. It was always very robust with the chimerism.
Thank you very much again. Thanks so much for joining and looking forward to seeing you hopefully in person next time.
Thank you so much. Bye.
Thank you. With that, I would ask Dr. Parkman to please join and reach the podium to introduce our closing keynote speaker.